trauma from occlusion or TFO. So trauma from occlusion is when the occlusal forces, means there are abnormal occlusal forces acting onto the periodontium, or the normal forces of occlusion which are acting on compromised periodontium. Okay. So it is of two types, primary and secondary. In primary trauma from occlusion, what happens is there is increased in the occlusal forces. Okay. Increased in occlusal forces, and the periodontium is normal, completely healthy. There is no inflammation, no periodontal pocket, no bone resorption, no attachment loss. Okay. In this, the periodontium is completely healthy. So, this kind of cases, the primary trauma from occlusion, it occurs in high points, inner filling, okay, placement of crowns. If the occlusion is not adjusted, okay, in a restoration, if the occlusal forces are not adjusted, if the, there are high points in a crown or in a restoration, then it can lead to primary trauma from occlusion. Okay. Then abnormal orthodontic forces. Okay. Now in secondary trauma from occlusion, what happens is there are normal, the occlusal forces are normal. Okay. And the periodontium is compromised. Periodontium is compromised. So what happens here is there is, because the periodontium is compromised, there is clinical attachment loss, there is bone loss, okay, because of inflammation. The normal occlusal, the periodontium cannot bear the normal occlusal forces also. So in such cases, there is secondary trauma from occlusion. Now, this secondary trauma from occlusion can occur in patients with periodontitis, be it chronic, aggressive periodontitis, in cases of gingival enlargement, in cases of patients under systemic influences. All these things can lead to secondary trauma from occlusion. Now, TFO can also be classified as acute and chronic. So acute means sudden abnormal forces. Okay. So these sudden abnormal forces can act during biting. So suppose we are trying to eat walnut or break the walnut, the outer shell of the walnut. At that time also sometimes abnormal forces are acting on our tooth, or we are trying to open a bottle of any cold drinks. These can lead to abnormal forces on TFO. Or there is a, in cases of filling, if there is a high point, or in cases of crown placement, FPD placement, there is a high point. All these factors can lead to acute trauma from occlusion. Okay. And in this cases, there is pain. Sudden pain, acute pain is there to the patient. The patient will come immediately to you. Supposedly you have done the patient in the morning, the patient will come in the afternoon to you कि डॉक्टर साहब बहुत पेन है. Then there will be TOP, tenderness and percussion. Okay, thermal sensitivity might develop. If the patient is like not getting it treated and bearing it, then patient may develop sensitivity also. Okay, in chronic cases means the forces are acting, abnormal forces are acting for a longer duration onto the tooth. Okay, abnormal forces are acting for longer duration. Okay, such duration. Now, such type of forces act during, parafunctional habits, abnormal orthodontic forces. All these cases can lead to chronic trauma from occlusion. And in these cases, what you will notice will be, there will be wear facets present. There will be, pathologic migration of the tooth. There will be mobility of the tooth. It means mobility will be the first sign of trauma from occlusion. Okay, all these changes you will see in chronic cases and not in acute cases. Okay? Now, let me show you the diagrammatically what are the changes that are occurring. So in this, you can see that here the periodontium is normal. Okay. The gingiva is completely normal here. You can see there is no periodontal pocket formation. The alveolar bone is completely healthy. So this is the normal height, normal alveolar bone condition. So the forces, abnormal forces which are acting on abnormal forces which are acting on a normal periodontium. This will lead to primary trauma from occlusion. Okay. Now, in compromised periodontium means what? Here you can see there is reduction in the bone height. There is clinical attachment loss. This much amount of attachment is lost. So in this, what will happen is the occlusal forces are normal. Occlusal forces are normal. But now the periodontium is lost to this much level. More than half of the periodontium is lost. More than half of the support of the tooth is lost. So in such cases, the tooth cannot bear the forces. Normal forces are also not bearable to the tooth. Okay, so this is your primary trauma from occlusion. Or in this, what has happened is there is a deep periodontal pocket present. Here the periodontal pocket is not deep. Here there is recession, but here no recession is there. There is periodontal pocket present and there is alveolar bone resorption. This is also a compromised periodontium. So the forces in this is also, sorry, here secondary trauma. This is also your secondary trauma from occlusion. Okay guys, now I hope with the help of diagram you have understood. Okay? Now let us see the stages. The stages of tissue response. Stages of tissue response to increased occlusal forces. Increased occlusal forces. So the first stage is the stage of injury. Stage of injury. In this, what is happening is as soon as the occlusal forces, abnormal occlusal forces starts acting on the tooth, there are certain tissue changes that develop. There will be areas of pressure, there will be areas of tension. Okay, in some regions if the occlusal forces are like slightly excessive, then there will be normal tension and pressure zones. If the occlusal forces are more like they are very heavy occlusal forces, means very heavy occlusal forces are applied to the periodontium, then there will be destruction of the periodontium. There will be abnormal compression, abnormal tension that will be acting between the tooth and the periodontium. Okay, so in this, the body, the body always has a tendency to repair. Okay, the body has a tendency to repair the tissues. In this, what will happen is whenever there is abnormal forces acting onto the tooth, if there is slightly excessive force, pressure and tension, okay, pressure and tension, what will happen? Suppose in a single rooted tooth, this you might have studied in your ortho also. In a single rooted tooth, the fulcrum of rotation is at the junction of middle and apical third. It is at the middle third, okay? And multi-rooted tooth, it is the fulcrum of rotation is at the interradicular region. Okay, this is your fulcrum of rotation. So whenever there are excessive forces, okay, that are applied to the tooth, there will be areas of tension and areas of pressure. Why? Because the tooth has a tendency to rotate around the fulcrum of rotation. See this, if the tooth rotates, if an abnormal force is applied, the tooth will rotate. Okay, so here there will be area of pressure, here there will be area of tension. Here there will be area of pressure, here there will be area of tension. Okay, this is how the forces are acting onto the tooth. So what happens is if there is a slightly excessive pressure, it stimulates the resorption of the bone. On the pressure side, there will be resorption of the bone. So if this is your tooth, okay, if this is your tooth and here the pressure is applied, the forces are acting, and here there is pressure, here there is tension zone, here there is pressure, here there is tension zone. The tooth is rotating around the fulcrum of rotation. Okay, this is your bone. This is your bone. Okay. So here there will be bone deposition and here there will be bone resorption. At the pressure side there will be bone resorption. At the tension side there will be bone deposition that will be happening. Okay. So if there is slightly excessive pressure, what will happen? There will be resorption of alveolar bone with resultant widening. Okay. Resultant widening of PDL. Okay. At the area where there is slightly excessive tension, what happens? There will be elongation of PDL fibers, elongation of PDL fibers. Okay. So there will be apposition of alveolar bone. Apposition of alveolar bone. In the area of greater pressure, this is when slightly excessive forces are acting onto the tooth. There will be zones of resorption. There will be zones of bone formation. But when there are greater forces acting onto the tooth, okay, greater pressure, then there will be vascular changes as well as tissue changes. So let us see what vascular and tissue changes will be there. It produce what will happen is at the site of pressure, what will happen? There will be compression of PDL fibers. Okay, compression of PDL fibers, which produces, now what will happen? Whenever there is pressure, there will be compression. So the PDL fibers will now break. They will break and they will produce a zone of hyalinization. Compression of PDL fibers, which produces zone of hyalinization. Okay. Subsequently, there will be, because of the compression of PDL, there will be injury to the fibroblasts. Injury to fibroblasts and other connective tissue cells, which leads to necrosis. Okay. Now, the vascular changes which are produced because of the great pressure. Now, what will happen is within 30 minutes, there will be stasis or impairment of blood flow. Okay. There will be, in 2 to 3 hours, the blood vessels will be packed with RBCs. Okay. What is happening is within 30 minutes of compression, the blood flow in the region of pressure is decreased. It is stasis. So blood flow is decreasing. So what will happen? The RBCs will start accumulating in that region and there will be breakage of RBCs. Okay. Breakage of RBCs. And between 1 to 7 days, the blood vessels will disintegrate. Blood vessels will disintegrate. And because of all these changes, now the blood supply to this region is lost. So what will happen? Agar kisi tissue ko, if a tissue is not getting a blood supply, then there is necrosis of the tissue. So finally, between 1 to 7 days, depending upon how much greater the pressure is applied, there will be hyalinization initially and then necrosis. Okay. Hyalinization, zone of hyalinization is seen because of the vascular changes that are occurring into the tissue. Okay. Now, in the area of greater tension, in the area of severe tension, what you can see is, because of necrosis, now what will happen? Necrosis means there will be degeneration of bone and there will be bone resorption. So finally, because of excessive pressure, there is bone resorption. Now, because of greater tension, what will happen is there will be excessive stretching of PDL fibers. There will be thrombosis, hemorrhage. Okay. Tearing of the PDL ligament fibers, hemorrhage will be there. Tearing of fibers. And thus finally there will be resorption of the alveolar bone. Okay. So what changes did you see? if there is severe pressure and severe tension zones created during severe trauma from occlusion, severe occlusal forces, there will be resorption. Okay, simply you have to understand that there will be resorption in such cases. In slightly excessive pressures means only if the tooth is able, means only slightly excessive pressure is there, not long-term pressure changes are there, like in the cases of parafunctional habits when there are wear facets are present. Okay, so in those cases, there will be severe tension, severe pressure zones created, and there will be bone resorption whenever a chronic force is acting, chronic abnormal force is acting onto the tooth. But in sudden changes, and suppose there is in acute cases, what is happening? There is a sudden change in there is sudden increase in the occlusal force, but when a patient comes to the doctor, we remove it. A patient will come within a day because of the amount of pain the patient is happening, and the force is removed. So in those cases, what is happening? There is slight increase in the pressure and tension. So there will be areas of bone resorption and areas of bone formation that you will be seeing. Okay. So now histologically, how you will see is, this is the tooth which is on which an abnormal force is acting. Okay. And here you can see that, see here you can see, what is this? See, this is your tooth. This is your tooth cementum. Okay. This is your alveolar bone, guys. ठीक है, पता चल रहा है ना आप लोगों को? This is your alveolar bone. This is your molar tooth. This is your alveolar bone. This is your tooth. ठीक है, this is your tooth. अब जब इस पे abnormal forces, when abnormal forces are acting on it, what will happen? There will be areas of pressure and tension. Now the abnormal, in this, the fulcrum of rotation is located at the interradicular region and the abnormal forces are acting in this direction. Suppose, okay, the tooth is moving mesially. The tooth has a tendency to move in a mesial direction. So what will happen? Here, there will be a zone of pressure because the tooth is moving mesially. Here, there is a zone of pressure. Okay, यहाँ पे you can see the PDL space has decreased. This is how I am able to make out. See, दिख रहा है आपको इधर? The PDL space has decreased here. Okay, so this is your zone of pressure. And here, and also here the zone of pressure is there. Now here you can see the PDL, here the PDL ligament space has widened, means the fibers are getting stress. This is the zone of tension. ठीक है, this is the zone of tension, this is the zone of tension, this is the zone of tension here. All these are zones of tension which are created. ठीक है, ये tissue changes होते हैं. Now because of this, at the zone of pressure, if this is a slightly excessive force, at the zone of pressure there will be bone resorption, at the zone of tension there will be apposition of bone. ठीक है, clear? कुछ भी doubt है तो post it in the group, we'll discuss it. Okay, now the second stage is stage of repair. Stage of repair. Okay, अब in stage of repair, वैसे if in slightly excessive forces, normally also in the bone remodeling is occurring. So repair occurs normally in a normal periodontium. Occurs normally in a normal periodontium. The body has, see, the bone is a tissue that is undergoing remodeling. We have already seen normally also, because the occlusal forces, some amount of occlusal forces are acting on the tooth on a day-to-day basis. Some amount of pressure and tension zones are always there onto the tooth, and the tooth has a tendency to move mesially. All the teeth in the oral cavity have a tendency to move mesially. So, any point of time in a day, you will see areas of pressure and areas of tension in the tooth. Okay, and in the cases of repair, what is happening? The bone remodeling, the rate of bone remodeling has increased. Okay, whenever there is a tissue injury occurring, and if the forces of occlusion are slightly excessive, then there will be repair. Okay. So this remodeling, and if the forces of abnormal forces of occlusion will be there, then what will happen? At one side there will be continuous resorption, and at the other side there will be continuous deposition. So what will happen? There will be buttressing bone formation. Buttressing bone formation. Now what is buttressing bone formation? So if this is your teeth, okay, if this is your teeth and this is your bone, up continuously I am applying pressure here. Continuously the abnormal forces are acting on the tooth. So what will happen here? There will be tension here, there will be resorption of the alveolar bone. Okay? So resorption will happen in such a way that here at one surface of the tooth, this surface will undergo resorption, but the outer surface of the tooth there will be bone formation, because bone resorption and bone formation are happening simultaneously only. Remember this. ऐसा नहीं होता रहेगा कि सिर्फ bone formation resorption हो रहा है and bone formation नहीं हो रहा है. नहीं. One surface, if the supporting alveolar bone is undergoing resorption, if this is undergoing resorption, what will happen? There will be continuous deposition of the bone. Okay, and this continuous deposition, if it is occurring on the cortical plate, on the outer, this is your outer cortical plate, guys. Okay, outer cortical plate. If it is occurring in this region, then this will result in peripheral buttressing. Peripheral buttressing. And if it is occurring in your spongy bone, ठीक है, हो सकता है यहाँ पे the osteoblastic cells become active and lay down a new bone or increase in the bone formation in the spongy area or endosteal region, then it is called as central buttressing. Okay, clear? Because of the abnormal forces. This is the mechanism of the body of repair. Why repair is necessary? Because the body tries कि जब तक I can provide something that can bear the forces. जब तक I can increase the bone density, it tries कि जितना भी abnormal force आ रहा है, I'll try to bear it. But once the bone is not able to maintain it, the body says अब नहीं हो पाएगा, अब I am not able to maintain the force. Two things will happen. Either the bone loss will happen to that level that there will be mobility, there will be drifting of teeth, the teeth will move away from the abnormal force, whichever tooth or whatever the cause of the abnormal force it is there, the tooth will drift from that position. Okay, so there will be migration, pathologic migration of the tooth. Okay, or there will be tooth mobility, or the bone resorption will be to that extent that there will be exfoliation of the tooth. Okay, so this is the stage of repair. Now stage of adaptive remodeling. Adaptive remodeling is, guys, when the body is not able to I told you now this only, when the body is not able to bear the occlusal forces after a certain amount, it will drift. Okay, this is called adaptive remodeling, means it will drift away from the occlusal forces, or there will be bone resorption to that much level that tooth mobility will occur and it will get exfoliated. Okay, so that is adaptive remodeling. Now see here, so this is a normal tooth, this is your normal tooth. Okay, in normal tooth, here you can see this zigzag lines. These zigzag lines are areas of resorption and these straight lines are areas of bone formation. So normally also in the tooth, there are areas of resorption, there are areas of bone formation. Now in the injury cases, what happens is, in the injury cases, there will be increase in the resorption. So here, this y-axis shows you the percentage of bone resorption. Okay, and this x-axis shows you the number of days in which there will be resorption, there will be bone formation, bone remodeling occurring. Okay, so this is the stage of injury. So in injury, what will happen? Whenever the abnormal occlusal forces are happening, there is increase in the resorption. Okay, so this increase in the resorption reaches its maximum resorption state in 28 days. Suppose the abnormal force is starting on day 0, then in 28 days you will see the maximum resorption here. So maximum resorption in 28 days. Okay, important to remember for MCQs. After 28 days, what will happen? The resorption will come down. The resorption will come down and bone formation will increase. And this bone formation will reach its maximum level on day 60. Okay. On day 60, there will be maximum bone formation stage on day 60. ठीक है, day 60 यानी 2 months. Okay, approximately 1 month. Now, what will happen after in this stage of repair? Now, from after 2 months, they both are in balance. Means bone resorption and bone formation are in balance, and after approximately 4 to 5 months, okay, 4 to 5 months, there is a stage of stability, and this is your 6 months. The bone is remodeled. जैसे भी उसका the amount of forces, if it is not removed, if occlusal forces are removed, then the tissue will return to normal. But if the abnormal occlusal forces are not, see, TFO is reversible. Just remember it, TFO is reversible. But if the abnormal forces are not removed, then the tissue will adapt itself. The body has a tendency to adapt. It will adapt. How it will adapt? It will drift away from the abnormal occlusal forces, or there will be, the tissue will be widened. There will be increase in the mobility. The tissue will be widened in such a level that now the occlusal forces are no more harmful to the tooth. Okay. So in approximately 6 months, there will be, this is the stage of adaptation or remodeling. Okay. So this process which is occurring during trauma from occlusion, this is, see, this type of bone formation occurs even in extraction socket, guys. Even in extraction socket, after we tell the patient that we can do the implant only after 3 to 4 months. Why? Because immediately after extraction, what is happening? There is increase in the bone resorption. The osteoclast will come, and whatever the surrounding bone is there, it will start resorbing. It will lay down the soft osteoid matrix in the first 1 month. Then in 2 months, there will be, here in 2 months, bone formation will be there. But maximum strength, after 2 months, it will attain maximum strength up to which we can place the implant is attained after 2 months. You have to remember this. 2 to 3 months or 2 months ke baad bhi not that much strong bone is present, because it depends upon persons. It varies between person to person. Okay. Also, various systemic factors which influence the formation of bone. Okay. So these days are important. You must know it. Now, so these were the stages: stage of injury, repair, and remodeling, adaptive remodeling. Now, effects. What is the effect of insufficient forces? Effect of insufficient. So insufficient forces occurs when there is a missing tooth present. Okay. So what will happen if this is your tooth and अगर इधर, see, tooth, opposing tooth is always necessary. Why? Because this will help if the forces are maintained onto the tooth. Agar it's like vestigial organs. Third molars were useful in monkeys, okay, or our primates. Then they were present. But with the evolution trend, what is happening? Why? Because we are not using the third molars. Now what is happening? It is becoming a vestigial organ, and slowly, in many patients, we have seen that the tooth germ, even the tooth germ of third molar is not present. Okay, means third molar is completely vanished. Why? Because it is not getting used. Similar things happen in cases of this occlusal forces also. If a tooth is not getting, we are only, suppose this tooth is not present. Okay, if this tooth is not present here, what will happen? There will be no forces acting onto the tooth. Okay, there will be no forces acting onto the tooth. So what will happen? There will be thinning of periodontium. Thinning of periodontium. Periodontium. There will be thinning of alveolar bone. Thinning of alveolar bone. Okay, and this is called disuse atrophy. Disuse atrophy. Okay. So if this is not happening, what will happen? There will be thinning of periodontium, thinning of bone, and there will be increase in the mobility of the tooth, and it will exfoliate or it will become weak. Similar thing happens in the cases of unilateral chewing. when a patient is having a habit of chewing from only one side, you might have noticed, on from now onwards you should notice that the part which the patient is not using, there is large amount of calculus, there is large amount of plaque, plus the teeth in that region are more mobile. Why? Because the patient is not using that region, that the periodontium that there is not getting used, so there will be more bone resorption, more periodontal pockets will be there, attachment loss will be there, okay, more calculus will be there. Why? Because the patient is not chewing from that side. Therefore we ask a patient to chew, and therefore it is very much necessary. One of the most important reasons to get your missing teeth replaced is the opposite teeth will get weak, and in some time that tooth also will be like, it will be of no use. Okay. So one of the reasons of getting missing teeth replaced immediately is because we must maintain the forces of occlusion onto the opposing teeth, onto the adjacent teeth also. Okay, so this is the effect of insufficient forces, and I have told you that trauma from occlusion is reversible. This is important. You have to remember that if the occlusal forces, abnormal occlusal forces are removed, the condition of the periodontium becomes to normal. Okay. Now, signs of trauma from occlusion. Signs of trauma from occlusion. The first sign of trauma from occlusion is mobility. So why mobility occurs? Because in abnormal forces there will be bone resorption. As we have seen, in greater abnormal forces, there only at the area of tension, at the area of pressure, there will be bone resorption. So what will happen? There will be whitening of PDL, and because of the whitening of PDL, the tooth will not be able to bear the forces. The PDL ligament space will widen. So this is a case of trauma from occlusion, in which you can see here, this region, the PDL ligament has widened. It has started undergoing bone resorption. So this is your normal height of the bone. Okay, normal height ये है bone का. Normal height is this, and it has started undergoing resorption. See here, it has started undergoing resorption. So what is happening? There is PDL widening. PDL widening. ठीक है. Vertical bone resorption. So the first sign is what we see in a patient. When a patient comes to you, supposedly for any other reason, like for pain due to periapical abscess, the patient is coming to you, but you notice that there are mobility in the teeth and small wear facets you can see. So you can think, this patient can have trauma from occlusion, right? So the first sign of trauma from occlusion is increased mobility. Okay. Then other signs which you can see in the patients of trauma from occlusion is pathologic migration. I explained it to you that if abnormal forces, if the periodontium is not able to repair itself, and if the abnormal forces are not removed, what will happen? The tooth will drift away from the abnormal forces. Okay. So because of this drifting, what will happen? The teeth will move away from the occlusal forces. Here you can see the tooth is moved away. It has shifted anteriorly. Okay. And there is pathology. Because of this, what will happen now? When the tooth has shifted anteriorly, these all teeth, there will be derangement of all the teeth. Okay. So this is pathologic migration, drifting away from the abnormal occlusal forces. Also, there will be wear facets. So these are the wear facets. These are the small scoop or scalloped regions. Which you can see onto the tooth. Okay. This kind of wear facets can most commonly be seen in patients with parafunctional habits, in patients with bruxism. Okay. You will see this type of wear facets. These are wear facets. Now, other sign which you will see is this. This is your abfraction. What is it? Abfraction. Now, what happens in abfraction is abnormal forces are acting onto the tooth, and the tooth elastic. The tooth is also elastic. It is not firm, right? So there will be dimensional changes between the enamel rods. Enamel rods, when, see, dentine is comparatively more elastic than enamel. Okay, this you have studied in your DADH. Okay, so now what will happen? Enamel is more stiffer, but dentine is elastic. So what will happen when abnormal forces are acting onto the tooth? There will be fractures, thin minute fracture lines will be created at the cervical regions of the tooth. Here at the cervical regions of the tooth, whenever the patient comes to you, there will be you can see some small cracks at the cervical region, and these cracks might extend into the coronal region also. Okay, so whenever you see cracks into the minute cracks into the tooth, enamel of the tooth, one of the reasons might be trauma from occlusion. Okay, so because of these cracks, what will happen? Many such cracks, such zone of fractures will be created, and there will be breakage of enamel from this region. Okay, from this region there will be breakage of enamel, and this will be abfraction, zone of abfraction. Okay, now there will be bone dehiscence. Bone dehiscence मतलब क्या होता है? Other signs which you will be able to see is bone dehiscence. Now bone dehiscence you will not be able to see clinically because there will be tissue here. यहाँ पे you will be having your gingiva. But what will happen in some cases? There might be recession. Okay, if the patient is coming at an early stage, three possibilities are there. या तो gingiva will be at a normal level and you will not be able to make out कि यहाँ पे bone dehiscence है, or you can see the color change. Okay, here the gingiva may appear translucent and thin. Or the third thing is there might be recession. The gingiva, because of the attachment loss, bone loss, the gingiva might shift apically, and here there will be recession. Okay, so in this case, what is happening? Bone dehiscence is bone dehiscence is loss of cervical bone. Okay, or the crest of the alveolar bone, or crest of alveolar bone. This is your dehiscence. This is important. This is asked in your picture based questions, that what is this? This is your dehiscence. And suppose this alveolar bone loss is not there. यहाँ पे भी bone है. Okay. If यहाँ पे भी bone है, but there is a hole like this. Cervical bone is present. Okay. And the bone has been lost only from this region. Only from this region. Then what you will see? There will be a hole. So this hole is known as fenestration. Fenestration. Okay, clear guys? So these were the signs of trauma from occlusion. So what are the signs of trauma from occlusion? Mobility is there, pathologic migration is there, bone dehiscence is there, wear facets is there, then abstraction is there. So these are the signs. And now in mobility, let me tell you some more things. So normal tooth mobility is between 10 micrometers to 150 micrometers. This is called as physiologic tooth mobility. Okay, physiologic tooth mobility. Now Miller has given the classification for Miller's classification for tooth mobility. Miller's index. This is called Miller's index for tooth mobility. It was given in the year 1938, and according to it, mobility is classified as class 0, 1, 2 and 3. Okay, 0 is your physiologic tooth mobility. 1 is greater than physiologic tooth mobility. Okay. 2 is the tooth can be moved. Tooth can be moved up to 1 mm or more in lateral, means mesiodistally, or in buccolingual dimension, lateral or buccolingual direction. Okay. And in class 3, what you will see, the tooth can be moved more than 1 mm in lateral direction, in buccolingual direction, and also in lateral and buccolingual direction, and also it can be depressed apically. The tooth can be depressed apically. Okay. So how can we check this tooth mobility? How to check tooth mobility? So this tooth mobility can be checked with the help of periodontal. First, manually you can check it with the help of probes. Okay, so what is done, the back end of the probe or the explorer is taken, and with the handle of mirror or probe, what you can do, you can place. So if this is your tooth, okay, here you have put the back end of the probe, and either two probes or mirror or probe you can take, and you can see the amount of mobility that is present. Okay, the other method is with the help of periodontal. So periodontal is a electronic device. So when you will keep the periodontal onto the tooth, there will be a passage of electric current. Electric current will pass through the periodontal, and there will be more mobility, and it will show some values onto the display. So this is your periodontal. I have a picture of periodontal as well. Wait, I'll show it. So this is your periodontal. So this tip is placed onto the tooth, and there will be vibrations, and these vibrations will show a display here. Okay, so this is your periodontal, and this periodontal can also be used to check the mobility of implants. Okay, this periodontal can also be used to check the mobility of implants. Also, with the there is a test to check the mobility that is known as Fremitus test. So in anterior tooth, what we do is we take damp fingers. We don't have to wear the gloves. We take the damp fingers, place it onto the anterior tooth, and we ask the patient to bite like this. So we can feel the vibrations, and sometimes we can see the vibrations by naked eyes. So accordingly, it is classified. The Fremitus is, so based upon the Fremitus test also, it is classified. Mobility, there are different classes to grade for the gradation of Fremitus test, which is class 1. In class 1, mild vibration or movements detected. In class 2, there will be easily palpable vibration, but no visible movements. And in class 3, you will see movements are visible with naked eyes. Okay. Now, radiographic signs of trauma from occlusion are, there is change in the shape of PDL, change in shape of PDL, bone loss is there, mostly vertical bone loss is there. Okay, then there is thickening of the lamina dura, now what is lamina dura? Lamina dura is the opaque zone. See here this opaque zone which you see na, white opaque zone, this is your lamina dura, and this is the region, this is also called as bundle bone, and this is the region where your sharpest fibers get inserted. Okay, thickening of lamina dura is seen, then thickening of the apical area is seen, root resorption or hypercementosis may also be seen, root resorption and hypercementosis. Okay, now let us see the role of TFO in progression of periodontal disease. In progression of periodontal disease. Okay, so because of the periodontal disease, it is seen that there is change in the pathway of inflammation. So there were two concepts given. One concept was given by Glickman, and the other concept was given by Verhong. So let us see what these two concepts are. Okay, so according to Glickman's concept, I have already showed you how a normal pathway of inflammation is. So normally what happens is, if this is your tooth, okay, and this is your gingiva, and this is your alveolar bone. Now what happens is, inflammation from the marginal gingiva, it goes to the supraperiosteal region and then it goes here. Okay, means what will happen first, this part of the bone will get resolved, and when it comes, the inflammatory mediators come here, it will get, this part will be getting resolved, and then it will go to PDL. Okay, so there will be mostly horizontal bone loss seen. Okay, but in trauma from occlusion, this is the normal pathway of inflammation. Normal pathway of inflammation from marginal gingiva to outer surface of the alveolar bone or outer periosteal surface. From outer periosteal surfaces goes to the inside alveolar bone, and from there it goes to the PDL. But in cases of inflammation, what happens is, it is seen that because of certain abnormal forces, Glickman saw that the supragingival plaque shifted apically. Okay, why he gave this concept was because according to him, he saw that the supragingival pathway, under the influence of abnormal occlusal forces, it became subgingival. Okay, so now what happens is, the bacteria will come here in the subgingival area. Also, the toxins which are secreted by the bacteria into the plaque, they also moved more apically. So now, what will happen? Because of the abnormal forces, the pathway of inflammation has shifted. Instead of going from here to here, it goes directly from the marginal bone, marginal gingiva to the periodontal ligament. So here, there will be inflammation of the periodontal ligament. Okay, so he divided the gingiva in zone of irritation and zone of co-destruction. Zone of irritation. Why this is called zone of irritation? Because here, whatever the source of irritation is, okay, what is the irritation? The plaque, the bacteria is the irritation. So this is called as the zone of irritation, is the major factor for the inflammation. But here in this zone, here, below the apical attachment of the base of the pocket, up till the alveolar bone is your zone of co-destruction. Why this is called as zone of co-destruction, guys? Because here the plaque, the toxins, the plaque or the toxins produced by the plaque, the toxins that are produced by the plaque or the other bacterial substances, they act onto the, what are, look, this is your alveolar bone. So alveolar bone के ऊपर क्या है यहाँ? Gingival fibers है ना? Here there is gingival fibers. So what will happen? Plaque and toxins are acting, plus the abnormal occlusal forces, the abnormal occlusal forces are acting here. Occlusal forces are acting here, which leads to destruction of these gingival fibers. So what will happen? Either this is called the zone of irritation, this is called the zone of co-destruction. Why? Because the plaque and abnormal forces are acting together in this zone, which are leading to destruction of gingival fibers. Okay, destruction of PDL. Thus, now what will happen? The pathway always, the inflammatory pathway always takes the path of least resistance. Okay, so now as there is destruction of the PDL, there is destruction of the gingival fibers, the inflammation will easily spread from the zone of irritation, from the marginal gingiva to the PDL region, to the periodontal ligament space, and there it will cause bone resorption. So the bone resorption will start here from inner side, plus there will be destruction of the PDL fibers leading to attachment loss. Okay, clear? This occurs in the cases of when there is gingival inflammation present, and this was Glickman's concept. Okay, So, zone of irritation and zone of co-destruction, I hope you have understood, and now you will not forget it. Okay. So now, according to Glickman's concept, there are four possibilities. Four possibilities that can occur when a tooth is exposed to the gingival inflammation, when a tooth with gingival inflammation is exposed to trauma. So there are four possibilities that can occur when a tooth with gingival inflammation is exposed to trauma from occlusion. It may alter pathway of extension or pathway of inflammation, which may result in angular bony defects. Okay. Therefore, most commonly with trauma from occlusion, what you see is the angular bony defects. Okay. Or it may favor an environment for the formation and attachment of plaque. Okay. Favor environment for attachment and formation of plaque and calculus. Okay. And thus it leads to, what happens is there is shifting of supragingival plaque gets converted to subgingival plaque, and thus there is more chances of inflammation. Okay. The toxins from the bacteria penetrate the tissues easily as there is destruction of the gingival fibers, PDL, and there is increased tooth mobility. Okay, so these are the four things that can occur when a teeth with gingival inflammation is exposed to TFO according to Glickman. Now, Verhong was the other scientist who was studying about trauma from occlusion. Okay. Now, according to Verhong, he said that for a bacteria to act on a tissue or for a bacteria to act on the bone, it must be present within a certain radius, within a certain diameter. It must be present only then it will be able to show its effect. Okay. So he said that the reduction in alveolar crystal height was related to presence of subgingival plaque in a range of 0.5 mm to 2.7 mm. Okay. He gave the concept of radius of action. So he said that trauma from occlusion has no role. Trauma from occlusion has no role in causing the tissue destruction and bone loss. See, he said that even if trauma from occlusion is not present, there is presence of infrabony pockets. There is presence of vertical bone resorption. Okay. So according to him, the main cause for inflammation or for vertical bone resorption was this: the subgingival plaque acting in a radius of up to 2.7. Okay? Understood? See, the concept of radius of action is you have to remember that Grant and Cho suggested that locally produced bone resorption factors need to be present in proximity of bone surface to exert their effect. Page and Schroeder Okay, this is important, guys. You must know this can be asked in MCQs about the scientist. Okay. Page and Schroeder, on the basis of measurements that was given by Verhong, said that the range of effectiveness for the bacterial action is between effectiveness for bacterial action is between 1.5 to 2.5 mm. This is your radius of action. So what these three scientists, Page, Schroeder, Verhang, and Grant and Cho, what all these scientists meant saying is, in simple words, if this is your tooth, okay, and if this is your gingiva and your alveolar bone. So, if the bacteria is present here, what will happen initially? There will be destruction of the tissues, okay. This destruction of the tissue will occur in the range of 1.5 to 2.5 mm. Now what will happen? The bacteria will come here near the bone. Okay. अब in anterior region, suppose we take the example of anterior region, and as you all know, in the alveolar crest thickness in anterior region is the anterior cortical plate is very thin, guys, right? It is not it is not thicker than 2.5 mm. It maximum 0.5 mm to 1 mm hoga, right? So when the bacteria comes here, I am talking about the anterior region first, okay? So if the bacteria has come here, so now this thickness is 0.5 mm, suppose, okay? And here the distance is 1 mm. So now what is happening? The distance, this total distance is between the bacteria and the outer plate. This total distance is This total distance is 1.5 mm. Okay. Now in this 1.5 mm, this bacteria can easily exert its effect and will cause bone resorption. So itna pura part bone resorb ho jayega, and this will be your horizontal bone resorption. So in mandibular anterior region, you will mostly see horizontal bone resorption unless and until कुछ region, जैसे ही what happens now, alveolar crest से हम नीचे आए, here we come here, and the thickness of the bone increases in this region. Now the bacteria is here, okay? Here the bacteria is there, and the distance from here till here is now up to 2.5 mm here. So the bacteria will exert its effect in up to this region only. उससे आगे उसका effect नहीं जाएगा. So what will happen now? Bone will get resorbed till this region. Okay, till this region the bone will get resorbed. So now the shape of the bone is like this. Okay. So what is this now? This is your vertical bone defect. Now the bacteria has resorbed the bone from here. It has decreased its resistance. It can easily move forward now. So the bacteria will now move forward. Come here. Now this distance is decreased. Again it will act up to 2.5, 1.5 to 2.5. Again it will cause bone resorption. So ये part भी bone resorption हो गया. You are understanding how the bone resorption is going on. You are understanding the concept of radius of action. This is your radius of action, okay? The bacteria, the bacterial toxins, this is for everyone. So I hope this is clear now, the concept of radius of action, okay? Now, what will be the treatment of trauma from occlusion? The treatment can be occlusal adjustments, okay? Occlusal adjustments you have to do with the help of, you have to take the articulating paper, you have to ask the patient to tighten your centric relation, you have to ask the centric occlusion, you have to ask the patient to give your lateral movements, protrusive movements, to record high points, okay? Then you will record it with the articulating paper and you will reduce those high points, okay? You can management of parafunctional habits. Now how management of parafunctional habits? Suppose the patient is having bruxism. So you will give a night guard, right? The patient, you will give the patient to wear the night guard, so that mostly the patients have a habit of clenching during night. So the night clenching will be reduced. The forces that are acting at night will reduce as the teeth. Night guard क्या होता है? Suppose this is your upper tooth and this is your lower tooth. A night guard is placed between, a night guard is placed in this region like this. It is a tray. Okay, so the tooth gets separated. Tooth gets remains separated and no forces are acting on them. Okay, or any other parafunctional habits the patient has. Now splinting of teeth is done. Splinting to is done in it is done to reduce tooth mobility. Okay, splinting of teeth is done. Then orthodontic tooth movement. Suppose an a tooth is rotated. Only a single tooth in a arch is rotated and it is exerting abnormal force to the tooth. Then what we'll do? We'll try to bring the tooth to its normal position so that those abnormal forces are removed. So this is done with the help of orthodontic tooth movement, right? Next is occlusal reconstruction. Extraction of teeth. This is the last resort. Extraction is last resort, guys. Okay. Last resort. So this completes our trauma from occlusion. We have seen what are the different types of trauma from occlusion, what are the stages of tissue injury, repair and remodeling, adaptive remodeling. We have seen various signs which the patient will show on when the patient comes to the dentist. Various signs of trauma from occlusion. Signs of trauma from occlusion are very important. The first clinical sign to appear is tooth mobility. Don't forget it. Then we have seen the classification of tooth mobility, about the Fremetis test classification, various grades of Fremetis test that can be seen. Then we have studied about the pathways of inflammation, Glickman's concepts, Verhong's concept, the radius of action, and finally the treatment. Okay, this completes our trauma from occlusion. Now, let us see patterns of bone destruction. See, we have studied the normal bone. Okay, we have studied about the normal bone and how bone remodeling is occurring. That also we have seen. Now, because of the inflammation, there are various areas of bone resorption, bone formation that are created into a tooth, into a periodontium. So, and it gives different, different appearances to the bone. So let us see what these appearances are. What are the changes that are occurring because of periodontal destruction of the bone or because of the inflammation. So the factors that are affecting the bone destruction are amount of plaque and calculus. ये तो हर किसी में ही होगा, ठीक है. जितना ज्यादा plaque and calculus उतना ज्यादा bone destruction. Trauma from occlusion, we have seen trauma from occlusion most commonly will cause vertical bone resorption. Then angulation of tooth and roots. All individuals have their tooths in different directions, right? They are not straight. Tooth in all the individuals are not straight. Some are inclined mesially, some are inclined distally, some are more coronal, some are more in infraocclusion. Okay, all these directional changes are there into the tooth. So angulation of tooth and roots will affect the type of bone pattern that you will see. Then thickness of the bone. Thicker the bone, more will be the vertical resorption. Thinner the bone, there will be horizontal resorption. Thickness of bone. Thin bone will undergo resorption at a faster rate than a thicker bone. Interdental spaces between the teeth. Root and bone morphology. Morphology and proximity from one tooth to another. Now, let us see the different types of bone defects which you will see. We have already seen the first different bone defects which you will see. First is your fenestration. So in fenestration, what you will see, there will be presence of marginal bone. The marginal bone will be intact and here the bone will be intact. Okay. And only at some specific, this is a developmental anomaly. This is because of some developmental anomaly. It can be because increase in the thickness of root in this region. ठीक है, क्या हो सकता है? Because in this region the root might be curved. ये हो सकता है, इसलिए the bone is thin there and it gets resorbed with time. Or because of endodontic tooth perforation, what happens? In this region, the bone has started getting resorbed, and only in this region there is a fenestration. So in fenestration means, just remember guys, fenestration is a hole. Fenestration is a hole, and in this the marginal bone is present. It is like a circle, and all surrounding bone is clearly present in fenestration. Okay. And in dehiscence, we have already seen the marginal bone is not there. Dehiscence, there is loss of marginal bone. Loss of marginal bone. So what is happening in dehiscence? Like this. So you will see here recession might be present, or tissue might be adhered to this region, and so there will be color changes into the gingiva. Now, see, these two things are asked in image-based questions. Okay, they have asked it in the NEET exams in image-based questions, that identify what is what. Okay, what is fenestration, what is dehiscence? So you must know what is fenestration. Don't get confused. Dehiscence or fenestration. Fenestration, remember, fenestration is a hole. Okay, hole. If you will remember what is fenestration. Now, 20% of tooth have either fenestration or bone dehiscence. Okay, fenestration and dehiscence are most common on facial walls and on anterior tooth region. Why? Because anterior cortical plate is thin. We have already discussed. So there are more chances of bone dehiscence and bone fenestration, because bone can be easily resorbed from that side. Okay. Now, exostosis. What is exostosis? It is overgrowth of bone. Most common onto the palatal side, palatal aspect, and this might interfere with your dentures also. Maxillary denture, you will not be able to place it, so you have to remove it. And if the patient is not denture wearer, then it may cause blanching of the mucosa. Okay, because of the increase in the size of the bone, palatal bone, there will be blanching of the mucosa, and it should be surgically removed. You know, tori is also a kind of exostosis, and in some patients it is very prominent. So you might be knowing that if the tori is present into the mandibular region, we keep it because they provide retention to the mandibular denture. But in the maxillary region, we have to remove it, because surgically we have to remove it, because there will be no retention and the denture will fall down. Okay. Now, buttressing bone formation. Buttressing, I have already told you what is buttressing. There are two types of buttressing, central and peripheral. Okay, this is also a type of exostosis. There is increase in the growth of the bone, increase in the deposition of the bone. That is called as buttressing. Okay, central buttressing occurs in the marrow spaces, and peripheral onto cortical plates. Okay, so I'll just show you the picture. So this is your peripheral bone buttressing. Here what you see is, this is your peripheral bone buttressing. So if you will look from this is your buccal aspect, right? This is your maxillary molar, and this is your buccal aspect. Here what you see is, see here, this is lipping. This is called lipping. Why? Because the crestal region has increased in size, while below the bone width is normal, but here at the crestal region, at the marginal region, the bone width has increased. Okay. So if this is your tooth, suppose. So what will happen? And this is your alveolar bone. Here, like this, there is increase in this overgrowth of the bone. This is called as peripheral buttressing. This is called as peripheral buttressing. Okay. And this is also known as lipping. Why lipping? Because of it looks like a lip now. It looks like a lip. Therefore, it is called lipping. So what will happen now? Because here there is, as you can see here, क्या हो रहा है? The bone width has increased. So here also, what will happen? The gingiva will also increase. Gingiva तो इसी का ही shape लेगा ना guys. Understood? So now what will happen? More of plaque and calculus will get accumulated here. More of plaque and calculus will get accumulated here. So more of infection. This is a retentive area for plaque. This is a retentive area for calculus. Okay. This becomes a retentive area. So we need to remove it and bring it to a normal architecture. We have to bring it to a normal architecture. We have to remove this portion. Remove this portion. Okay. This is your central and peripheral bone buttressing. This is your peripheral bone buttressing. In central bone buttressing, there will be increased deposition into the marrow spaces. Okay, there you will see thickening of the bone.